Welcome to Neurosense. I'm Virender Bhan, a neurologist here at the Fraser Health MS Clinic in Burnaby, BC. And today I'm going to provide commentary on the sixth and final case for this case series. I'd like to thank Neurosense for creating this program and you, the audience, for participating. Firstly, about the case. Joseph is a 28-year-old gentleman, otherwise healthy, who presents with right optic neuritis. So he has fairly rapid onset of loss of vision in the right eye with minimal or no pain. On examination, he has visual acuity of 20/400, loss of color vision, and an afferent pupillary defect. Rest of his neurological examination is completely normal. And the only relevant historical fact is that he has never had the COVID-19 vaccine and refuses to have it. His MRI scan shows multiple white matter lesions in keeping with a primary demyelinating disorder. He also has a T2 hyperintense lesion in the right optic nerve, which shows gadolinium enhancement. He's given a course of IV steroids, Solu-Medrol 1,000 milligrams daily for 3 days, and has minimal recovery. So before proceeding to the questions, my own take here is that, yes, this is optic neuritis. Yes, we're going to work him up for multiple sclerosis, but there are already 3 atypical features here. One is the severity of the vision loss. Second is relative absence of pain in the eye. And the third is hardly any response to IV steroids. This should make us wonder about, is it really MS or could it be something else? And therefore, broaden the diagnostic workup. So the question number one is, what is your provisional diagnosis? And 28% said CIS. That would be okay. 15% said other. And I'm presuming these people are like me. They're thinking about other possible considerations, including neuromyelitis optica. But about 40% of respondents actually said, yes, it's MS. And I'm now wondering whether the wording on the gadolinium enhancing lesion was kind of confusing, because as per 2017 diagnostic criteria for MS, a GAD enhancing lesion, symptomatic or asymptomatic, can be counted for dissemination in space and dissemination in time, but not if it's in the optic nerve. So GAD enhancing lesion has to be in the brain or spinal cord. And in his case, the lesion is in the optic nerve. And so one cannot make a diagnosis of MS here. Now, is it fair to exclude optic nerve? That's up to the panelists that decided on that. And I would also actually point out to an article that was presented last year in Neurology by Vidal, Jordana et al. They are a group from Barcelona that presented a cohort of patients who had optic nerve involvement as per VEP and OCT, and thus increased the diagnostic specificity and sensitivity in MS. So they're making a case for inclusion of optic nerve lesions. And there's an editorial accompanying as well. So we'll have to wait for the next iteration to see if they include, but for now, one cannot confirm a diagnosis of MS here. Question number 2 was, what additional tests, and you were allowed a maximum of 3, would you be interested in doing on this gentleman? And there's complete agreement here. More than 90% said spinal fluid assessment, spinal cord MRI, and antibody testing for NMO and MOG. So I'm totally in agreement with that. And then the question number 3 was, would you initiate a DMT? And 58% said they would defer because the diagnosis is not certain yet. And I'm in that camp, I totally agree. But 42% said they would start a DMT. And I think these are the people who made the diagnosis of MS, and I've already made a comment about that. So as this patient is being worked up, 3 months later, he develops myelitis. So he has fairly rapid onset of interscapular pain, numbness and weakness in the legs, bladder control issues. This gets to the point he's unable to walk, he's hospitalized and investigated. And the next few investigations are again similar. They kind of leave you in a bit of a limbo. For example, the spinal cord MRI shows 2.5 vertebral body segment size lesion. So not quite 3 or more that is typically seen in NMO, but getting there. He has 39 WBCs in the spinal fluid, and mostly in MS, you see a low number of WBCs. Now, the cutoff supposedly is 50 or more. That should not happen in MS, but 39 is kind of getting towards 50. And then his oligoclonal banding is not positive in the standard sense, which is 2 or more bands. It shows you 1 band. So kind of all tests could be in keeping with MS, but could also be in keeping with NMO. Now, his antibody testing for MOG is negative, which is not surprising because MOG patients tend to respond very nicely to steroids. Antibody testing to NMO is negative, but then the sensitivity in the best labs in the world is about 70 to 80%. So he could still have seronegative NMO. And he's given a course of steroids again, this time Solu-Medrol 1,000 milligrams daily for 5 days, and there's partial recovery. So he's still left with some significant deficits and is discharged from the hospital. And the question number 4 is, how would you treat this patient in terms of DMTs? Whether you are in the MS camp or in the seronegative NMO camp, we all agree that this is aggressive presentation. So this young man has had 2 bad attacks with incomplete recovery in less than 6 months. So we need to put him on one of the high efficacy therapies. And I'm happy to see that nobody selected platform agents, nobody selected first-line oral agents. 28% said natalizumab. I'm presuming this is the camp that is still thinking this is MS, and they could be right. And 52% chose the B-cell depleting therapies, which would probably cover both MS and seronegative NMO. And then a smattering of just a couple of people chose fingolimod or cladribine. And the final question, question number 5, is about how does his COVID vaccination status affect your DMT treatment decision? About a half, 44%, said that just select the best possible DMT that suits him and do not worry about the vaccination status, and I'm absolutely in that camp. 28% said select a DMT that doesn't deplete the B cells or the T cells, so they were going towards natalizumab, and that's like possibly okay if this turns out to be MS in the long run, but we just don't know. So in conclusion, in real world, when you're investigating patients for multiple sclerosis, sometimes there are imaging, clinical, and CSF criteria or CSF findings that are atypical for MS, but not quite diagnostic of NMO. And in these patients, one should be aware of the relative red flags, should investigate these patients fully, and ideally choose a DMT that covers both. Thank you for your interest and attention.